All right, so this chapter is all the anatomy about the shoulder complex. The shoulder is a very complex joint because it's more than just one, you know, one joint. It's actually a group of four joints that have to work together in order for motion to occur. Um, Anatomy of the shoulder is one of the hardest things that you're going to have to do. So those of you who are, this is your first eval class, you're starting off with one of the hardest things you can do. But overall, figuring out how to diagnose the injury is still using the regular evaluation process. But because of all the bones that are moving with the shoulder, because of all the muscles that are involved, we have a lot of range of motion. Because we have so much range of motion within the shoulder, there is a lot of things that all have to work together in order for the shoulder to work correctly. So when one thing stops working, that's when injury can occur. So diagnosis is relatively difficult. There are a bunch of special tests that we'll get into in the next part of the chapter. And even those special tests, there's a ton of them, but they're not always very conclusive. So you really have to understand your anatomy and how it all works together so that you can figure out the exact diagnosis later on. So the upper extremity, what we call the upper extremity, is the arm, the shoulder, and everything that's attached to that distally, so the elbow, hand, wrist, forearm, fingers. That is all attached to our body by one joint. One true bone-on-bone joint holds our entire arm to the rest of our body, and that is the sternoclavicular joint. So where the sternum in the front meets the clavicle, that is called the SC joint, and that is the only bone-on-bone contact that's holding our entire arm to the body. So what that means is there's not a lot of bony stability. We're relying a lot on muscle and ligaments to hold our arm tightly to our body. So when I talked previously about how important shoulder and scapular stabilizers are, that's what I'm talking about here. If those scapular stabilizers are not strong, then we're going to have a lot of problems with our shoulder because there really isn't any other stability. So the upper extremity is made up of the shoulder, elbow, hand, wrist, fingers, and all of that is, again, hanging on by just the sternoclavicular joint. So like I mentioned before, the shoulder is actually a group of multiple joints, multiple bones, and muscles that all have to work together in order for us to have full motion. So we call this the shoulder complex or the shoulder girdle because when you think of the shoulder, you really just think of the glenohumeral joint where it's the humerus moving on the scapula. But in reality, it's a lot more than that. It actually involves the sternum and the manubrium in the front. Then the clavicle is going to attach to the sternum and move on out. Then it's going to attach to the scapula, and then the humerus is going to attach to the scapula as well. So all four of those bones are going to be working together in order for us to have full movement of the upper extremity. So we're going to start off here going over the joints, then we'll cover ligaments with each one of these joints, and then later on we'll get into the muscles. So starting off, here's a good picture like what I was talking about earlier. The entire upper extremity is held on to, we call it the axial skeleton, the rest of the body, by just this SC joint right here. That is the only bone-on-bone attachment. So again, very small joint, it is a strong joint, but in the grand scheme of things, not overly strong. So we again have to rely a lot on our muscles to keep our arm working correctly and attached to our body. But at the SC joint here, we have a relatively round end of the clavicle. If you remember what the clavicle looks like from lab, or if you see in the clavicle, this is very round. And the sternum, the manubrium here of the sternum, is relatively flat. So we have a round structure sitting in the clavicular notch of the manubrium that is relatively flat. So when it comes to bone-on-bone contact, it's not an overly strong joint. What makes it strong is its ligamentous support. When we go through these slides here, I'm going to have these bullets on the side of different anatomical terms that I want you to know. Those are what I'm expecting you to know for the exam. So on the sternum here, I want you to know what the manubrium, that's the top part of the sternum. It's fused to the rest of the body here, but it is technically a separate piece. The jugular notch is just a spot in the top here. The very top part, you'll have your trachea and esophagus right behind that. Then you have your clavicular notches on each side, and that is where the round end of the clavicle is going to sit for the sternoclavicular joint. Then we have this thing called a sternal angle. The sternal angle is where the manubrium meets the rest of the body, and if we look at this from the side, you actually can see a slight angle. So from the front, you can't really tell, but from the side, this is going to have, kind of an angular shape. So it's going to be different in everybody, but if you palpate, you start at the jugular notch and you palpate it down, this area right here does stick out a little bit more in the average person than the rest, and that's your sternal angle. The body is all the rest of it, and then your xiphoid process is the tip at the very bottom. And then you can see here that this is where the ribs, the costal cartilage of the ribs, are going to attach. The clavicle, other part of the ST joint, you need the sternum, and now we need the clavicle. Not very complex bone. It is pretty small. It definitely has an S-shaped curve to it. It's really going to be important for you to understand, what the general makeup is. How can you tell a right from the left, top from the bottom? One of the main things here is when you look at the medial side of the clavicle, the side that actually attaches to the sternum, that side is going to be a lot more round than the other end. If you look at the other end where it actually attaches next to the acromion or to the acromion, that end is really flat. So the medial side is round, the distal or lateral side is going to be flat. We also know that the clavicle is a lot more, it's sticking out, it's a lot more anterior, it's a lot more pronounced, closer to the sternum. So if you were to actually palpate your clavicles and you started by the sternum, they're very prominent in the front. So that proximal 2/3, they're anteriorly convex, so they're sticking out in the front. As you follow them down, then they're actually going to disappear further as it heads out to meet the acromion. So they're round on the sternal end, they're flat on the acromial end, they're much more anterior on the sternal end, moving more posteriorly on the acromial end. So the best way to do this is really to spend some time in the lab and actually look and hold these different clavicles so you can figure out which end is which and what they actually look like. So getting back to the specific sternoclavicular joint here, there is a disc where the clavicle meets the acromion. It is a fibrocartilage disc. It is a disc like you would see like in the meniscus in the knee. Most discs in our body, there's a reason we have them, and then most of the time it's for shock absorption and adding joint stability. So like I said earlier, we have a relatively round end of the clavicle, sitting here, and then we have a relatively flat manubrium. So round on flat doesn't necessarily give us a lot of stability. So what we're able to do is actually, we have a disc in there, and the disc is going to add that stability. It's going to deepen the socket so that we are able to have a little bit more contact. We want more, it's not going to be bone on bone, but we want more things touching. The more that's touching, the more stability you're going to have. So within the entire body, we have discs for a reason. Discs are there for shock absorption and adding joint stability because it makes that contact a little bit more. The primary ligaments of the SC joint, we're going to have our costoclavicular ligaments. Costoclavicular, really, these are long words. These ligaments they have long names. But if you stop for a second, you read it and you say costoclavicular. Costo is always going to mean ribs. Clavicular is your clavicle. So this ligament is going to go from the rib cage to the clavicle. So where is that at? Over here. This is our first rib, and the ligament is going to run from the first rib up to the clavicle. Its job is to prevent elevation. So as the clavicle is trying to move up, it's going to stop that. So that's your costoclavicular. Then you have your anterior sternoclavicular ligament. Sternoclavicular joint is where the clavicle meets the sternum. That's the joint. The anterior SC ligament is on the anterior side of that. So this is very palpable because it is on the anterior side. This is going to resist any kind of anterior-posterior displacement. So if there was direct contact or movement of the clavicle anteriorly or posteriorly, this ligament will help stop that. We also have a posterior SC ligament. We cannot obviously palpate that unless you can, get them to relax enough to move around the posterior part of the SC joint. But you can think about it, these anterior-posterior kind of together, forming a complete circle. They're really just kind of wrapping the entire SC joint into one big capsule that we just separate into two names, even though it's kind of one specific structure. And then we have our interclavicular ligament. Interclavicular, we're going to connect the two clavicles together. So it's running from one SC joint, from one clavicle down and all the way over, and this is going to help prevent downward movement. So as the clavicle tries to move down, it will prevent that from happening. So, like I said, not a lot of bone-on-bone stability within the SC joint, but because we have the disc and because we have these relatively strong ligaments, this is a pretty stable joint. It does take a lot of force for us to damage the SC joint. Then we're going to move out to the AC joint. So the structures of the acromioclavicular joint are going to be the acromion, which is part of the scapula, and the clavicle. So we already covered what's going on in the clavicle, now we're going to cover what's going on in the scapula. I like this picture because it shows you from all three different angles. Again, I'd recommend going into the lab and picking up a scapula and actually looking at it. Is it the right? Is it the left? What's it look like from the medial side, the lateral side? What's actually going on? On the next slide, there is a list of all the anatomical landmarks I want you to know. I really like this picture right here because it shows you a different angle. In this picture, this is the anterior side over here because here's your coracoid process, here's your acromion. Your body would be right here, your rib cage, and then your humerus is going to be sitting right in there. So looking at it from this angle, I like this because we're going to end up talking a lot about this subacromial arch, and you can easily see that from this angle. But we most commonly look at them from the anterior and the posterior side. When you do look at a scapula, it should be easy to tell which side is anterior and which side is posterior because you have the spine of the scapula right here that's going to be sticking out of the back. So the rib cage is going to be sitting along this nice smooth anterior wall where the spine of the scapula is going to separate muscle origin locations on the posterior side. And then it's going to lead right up into the acromion. So what I want you to know is obviously the acromion. That's going to be a very easily palpable structure. It is, you can pretty much find out anybody know how big the person is. It's going to be on the direct lateral side. If you follow the spine of the scapula all the way up, it's going to end up coming around to the acromion. I'll talk a lot when it comes to palpation about having anatomical landmarks that you can always find. And when it comes to the shoulder, there's a lot that you are not always 100% sure of. So, but what you should be 100% sure of is where the spine of the scapula is and where the acromion is. Those are two things that are very prominent in pretty much everybody, and they're going to be your kind of home base, your landmarks that you know where you're at as you start looking for things that you're not as comfortable with. The coracoid process is going to be the part sticking out of the front. So on this slide, this is your coracoid process up there. It is just kind of a projection sticking out anteriorly. Not a ton going on with that. It is easy to find. When you do palpate it, it tends to be very sensitive. I would say it's easy to find, as your shoulder kind of scoops in anteriorly and then your rib cage kind of scoops in, you have a crease where your shoulder meets the rest of your body, and right in there you'll find your coracoid process. We'll talk mostly about the coracoid process because there are 3 different muscles that originate or insert into that one bony landmark. We'll talk about those a little bit later. Spinal scapula, I already mentioned, that's something that's very easy to find. It is the spine running all the way across the posterior aspect of the scapula, and it's going to separate the supraspinous fossa from the infraspinous fossa. The glenoid fossa or glenoid cavity is the part where the humeral head is going to sit. So in this picture, it's going to be right over here. On these, you're looking right at it. That's where the humeral head sits. It's kind of that ball and socket joint. It's the socket part of the ball and socket joint. Our superior and inferior angles of the scapula. Your superior angle is just the very tip here. Your inferior angle, we've already talked about that in the posture assessment when we looked at the scapula. The inferior angle is just the very bottom tip. Then we have our medial or vertebral border, because it's by the vertebrae, so it's just the medial part, or in the lateral border, which is going to be underneath or on the side of the glenoid fossa. And then we have fossas. Fossas are going to just mean kind of indentations or holes or cavities. In this case, we have our subscapular fossa, supraspinous fossa, and infraspinous fossa. The subscapular fossa is going to be on the smooth side. So it's going to be on the anterior side of the scapula where it's sitting against the body. There's going to be one muscle, the subscapularis, that originates in this subscapular fossa. The supraspinous and infraspinous are going to be above and below the spine of the scapula. So if here's the spine of the scapula, this is your supraspinous fossa, where your supraspinatus muscle is going to originate. Below the spine of the scapula is your infraspinous fossa, where your infraspinatus muscle is going to originate. Again, I know it's a lot of similar words, but take your time, and they're really relatively easy to figure out. Okay, so this next thing, I've mentioned this before, I think we talked a little bit about it. We talked about regular planes of the body, the frontal plane, the sagittal plane, the transverse plane. In the shoulder, we talk about the scapular plane, or the plane of the scapula, or sometimes called scaption. Because the body is not square, our rib cage is rounded, the scapula is going to sit at an angle, and it's going to kind of have its own plane. So when we talk about scaption, it's kind of different than talking about the traditional planes of the body that are very cut and dry, that are very, I guess, linear. They're perpendicular to each other. Well, scaption is kind of in the middle of that. Because the rib cage is curved, the scapula are going to have to sit along the curved rib cage. So they're not going to be solely in the frontal plane right here, or solely in the sagittal plane right here, because we're in between that, because we're curved a little bit. So scaption technically is 30 to 45 degrees from the frontal plane. So if this is the entire frontal plane back here, we've rotated up about 30 degrees, and that's where the head of the glenoid, or the face of the glenoid fossa, is going to sit. If the glenoid fossa is sitting about 30 to 45 degrees away from the frontal plane, that means the humerus is got to sit there, because the humerus is in the glenoid fossa. If the glenoid fossa moves, so does the humerus. So that means the resting position of our shoulder of the glenohumeral joint is in this scaption. It's neither in frontal or sagittal, it's in the plane of scaption. The perfect example is like if you're standing still and you go to reach up from something in front of you, look at where your humerus is. So don't think about it, just reach up, like raise your hand, and your arm is neither all the way out in the frontal plane or all the way forward in the sagittal plane. It's in the middle. That's because that's where your scapula is resting, so that's where your humerus is going to go. So that's scaption. We talk about scaption because it's kind of the most comfortable position for the muscles in the shoulder. So when we start to do rehab, when we start to do special tests and things like that, we're going to actually put them into scaption because it puts the least amount of stress on the structures within the shoulder. So back to the AC joint. We talked about the bones, so the scapula and the clavicle that make up the AC joint. Now we have our the ligaments of the AC joint. So remember that AC does stand for acromioclavicular. So we do have our superior and inferior acromioclavicular ligaments. These are kind of like the SC, where we had our anterior and posterior. We're going to have superior and inferior here. So these are the ligaments that actually surround the AC joint. The AC joint is where the clavicle comes all the way out, and it actually touches or inserts at the acromion. So much like I said with the anterior and posterior SC ligaments, the superior and inferior are kind of just one big continuous joint capsule that surround the entire thing, but we divide it up into two names and call it the superior and the inferior. We can't really palpate the inferior one, but we can palpate the superior one. And the whole goal of these AC ligaments are to resist the clavicle from riding over one another. We were trying to keep these in the same place, but even though the end of the clavicle is flat and the acromion is relatively flat, there's still not a lot of bone-on-bone contact. So the bony stability of the AC joint is not really there. So we have to rely on ligaments to help us out. Then we have the coracoclavicular. Again, sound that out. Coraco is your coracoid process in your clavicle. So there are ligaments that run from the coracoid process up to the clavicle. There are two, these are split up into two separate ligaments, the conoid and the trapezoid. The conoid is going to be more medial. So this is medial over here because this is where the rest of the body is. This is going to be lateral. So your conoid is sitting more medial. Your trapezoid is more lateral. Your conoid is more of a triangle shape. Your trapezoid is more of a trapezoidal shape. Both of these are going to work together to limit, I would say, superior translation, so any kind of upward movement of the clavicle, as well as any kind of lateral movement. So they're really there to they're kind of pulling, kind of like guide wires from the bottom, pulling them down. We don't want this clavicle to pop up or to move left or right. So those are the three primary ligaments of the AC joint. When we hurt the AC joint, we can hurt, one, or, more minor injuries are going to just affect the AC ligaments. The more severe ones are going to affect the superior inferior AC and the coracoaclavicular ligaments. Then the last one we have is the coracoacromial ligament, and this runs from the coracoid process to the acromion process. Now, ligaments traditionally are going to run from a part of one bone to a part of a totally different bone. Ligaments are there to stabilize joints. Joints are usually made up of more than one bone. In this case, the coracoacromial ligament is a ligament, but the coracoid process and the acromion process are both part of the scapula. So the ligament is not really adding stability to the scapula because it's already part of the same bone. What this ligament actually does is forms the roof of the subacromial space. And we'll be talking, like I've already mentioned it earlier, we're going to be talking a lot about the subacromial space and the subacromial arch, or the coracoacromial arch. There'll be better pictures of this later on, but I think the important thing right now is to understand that this is a ligament. It's made up of the collagen fibers, the same ligament structures, but it's not holding two separate bones together, because if the scapula moves, both the acromion and the coracoid process are going to move. So it's there, it's adding stability to the shoulder, but not really supporting the individual bones. Then we have the SC ligament, or the SC joint, we had the AC joint. Now we have the scapulothoracic joint. This is not really a true joint because it's not a bone-on-bone contact. There are no ligaments involved here. This joint is solely about muscle stability. So this joint is held together by muscles. That's it. So it's not really a true joint. The scapula is supposed to lie over the 2nd through 7th rib. That's the average. The medial borders of the scapula should be about 4 inches apart, and we measured that in the postural assessments. We said 5 to 7 centimeters each from the spine, so 4 inches total. Like I said, it's not a true anatomical joint because there is no pure ligamentous attachment to the axial skeleton. Very, very, very important joint though, because our humerus, and where most of the motion comes from, is attached to the glenoid fossa. The glenoid fossa is the scapula, so if the scapula is not stabilized, we're asking for some real serious problems within the shoulder. The movement to the scapulothoracic joint, we've talked about these before. We have our retraction, protraction, upward, downward rotation, our anterior, posterior tilt, and our elevation, depression, all of the scapula. These motions are really important. In order for us to have full movement within the shoulder complex, the shoulder girdle, we need to have the scapula moving appropriately. By itself, if we look just at the glenoid fossa, just at the glenohumeral joint where the humerus meets the scapula, we actually have a limited amount of motion. If we say that the scapula was totally fixed to our body and was not able to move at all, we would be limited to about 60 degrees of shoulder abduction and shoulder flexion. We would not be able to even get to 90 and definitely not get overhead. So the importance of the scapulothoracic joint is really important for us to have the full mobility within our shoulder. When it comes to the actual makeup of the glenohumeral joint now, the last joint of the body, or the last joint of the shoulder complex, I always say that in the shoulder, we sacrifice stability so that we can have more mobility. Where I'll compare it to the hip next. The hip is a very stable joint, but it's not near as mobile in the shoulder as the shoulder is. The shoulder is not very stable. We dislocate shoulders all the time. The shoulders are really prone to injury because there's a lot of high forces going through them, and there really isn't a lot of stability there. When we actually look at how big the humeral head compared to the glenoid fossa, a good example is a golf ball on a tee, where we have a very large humeral head, a very large golf ball sitting on a relatively small glenoid fossa, which is the tee. It's about a 3-to-1 size ratio. The humeral head is about 3 times as large as the glenoid fossa. The more bone-on-bone stability you have, the more stability you have. If there's more bone touching, then that joint is more stable. The less bone that's touching, the less stable the joint is. So in this case, a 3-to-1 ratio, there's not a lot of bone touching each other, so this joint is not inherently stable. So like I said, we're going to compare this to the the ball and socket joint from the shoulder compared to the hip. Um, the hip is going to have a lot of bone on bone. Look how much it actually comes in here. There's a ton of bone on bone contact compared to the shoulder where there is very little bone on bone contact. It's a good thing because in the hip we have our entire body weight plus more, plus gravity, plus extra forces all going through the hip constantly. So that joint has to be a lot more stable than the shoulder, where the shoulder is not a weight bearing joint, so it does not have to be near as stable as the hip does. In the hip, there is a very big labrum, this fibrocartilage actual disc that helps, like all discs do, helps increase stability and increase contact area. Within the shoulder, we have a thing called a glenoid labrum, and this is it's kind of like, it's not really, it's the same concept as a fibrocartilage disc, but it's not made up of the same stuff. In the shoulder, the glenoid labrum is not made up of fibrocartilage. It's just really made up of a little bit denser connective tissue. It's not really there for shock absorption because it's not made of the fibrocartilage, but it is there to help add some stability. So if you look down in here, here's our glenoid fossa. The labrum is going to go around the fossa, but really that labrum is just kind of extra folds of connective tissue versus being that really strong fibrocartilage disc that is there for to help increase or help with absorption of forces and whatnot. We don't really have that. Like all synovial joints, the shoulder is it is a synovial joint. So that means it's going to have a joint capsule around it. And like I've said, joint capsules are kind of like saran wrap all the way around. So it's just connective tissue that is there to hold the entire joint in place. And it's synovial, so that means there'll be fluids and nutrients within the synovial fluid. So instead of the glenoid labrum being this big fibrocartilage disc, the glenoid labrum in the shoulder is actually just extra folds in that joint capsule that's already there. So again, it's not a big thick capsule or a big thick cartilage, it's just extra folds. So looking at it from the outside here, here is the humeral head is going to be in there. This is the glenoid fossa. Around that, this is all just joint capsule. And there are going to be just kind of extra folds right here by the glenoid fossa where we're going to have our labrum. So the important thing here is the glenoid labrum is technically considered a labrum, but it's not a fibrocartilage labrum, and it's not near as strong as other ones in the body. It's really more just folds of connective tissue, folds in the joint capsule, than actual fibrocartilage. That same idea is going to come back, and we'll also look at the ligaments, same kind of thing. But quickly here, we know these already. The movements of the glenohumeral joint. We have flexion, extension, adduction, abduction, internal external rotation, horizontal ab and adduction, and circumduction. And circumduction is a multiplanar movement because in order for us to do circumduction, we're going to have to combine flexion and some sort of rotation with adduction as we move around. So we are able to do a complete circle with our shoulder girdle. So this is more than just the glenohumeral joint moving. It's all the joints moving in order for us to get this full range of motion. So back to the glenoid labrum. Here's a good picture of it. That picture wasn't very good. So here's the glenoid labrum. Here's our glenoid fossa, and around that is the labrum. But again, not the fibrocartilage, really just folds of connective tissue. It's going to act like any other labrum, where its job is to help increase the depth or increase the contact, so more stability. If there's more surfaces touching, the more stable it's going to be. So like I said, it was thought to be made of fibrocartilage, but actually now it's considered more of these just dense connective tissue around the capsule. So not so much for the shock absorption. The shoulder, the glenoid fossa, is really a lot about just adding contact. One of the big things you need to know also about the glenoid labrum is that this structure right here, so when we look at this picture, here's the back, here's the spine of the scapula, here's the acromion coming from the front. So this is posterior, this side is anterior. Looking directly, the humerus is going to go right here. So we're looking into this person. This is the lateral side. This is a cut long head of the biceps tendon. So the bicep brachii is going to come up the front of the shoulder, of the humerus, and it's going to go in and actually attaches to the supraglenoid tubercle. So the top of the glenoid fossa is where the long head of the bicep tendon actually inserts. It also has insertion into the top part of the glenoid labrum. So the long head of the bicep tendon moves up anteriorly, attaches both to the top of the glenoid labrum and to the top of the glenoid fossa. So that means if we have pulling of the long head of the bicep tendon, we can also have pulling away of the glenoid labrum from the glenoid fossa because they're connected. So it's a really important concept to understand that the long head of the bicep tendon, it does have connection to the glenoid labrum. So if one is severely damaged, the other one might be involved. Specifically here, the humerus, the anatomy, we have our greater and lesser tuberosity with our bicipital groove. The intertubercular groove is also the same exact thing as your bicipital groove. Your greater tuberosity is going to be sitting more direct lateral. Then as you move inward or you externally rotate your shoulder, then you're going to get your lesser tuberosity. You're going to get your intertubercular groove or bicipital groove, and then you're going to get your lesser tuberosity. We'll practice that palpation in lab. That's something that you're going to want to know. The greater and lesser tuberosities are primarily muscle insertion points. The bicipital groove is where the long head of the biceps tendon actually runs through. So as we just talked about it, so as the bicep tendon runs up, it goes through the bicipital groove, and then it continues up into the shoulder where it's going to insert into part of the glenoid labrum and part of the superior glenoid fossa. Then we have our anatomical neck. So that's just the line directly below the actual articulating head for the humerus. It's not on here, but the surgical neck is on your palpation list for lab. Your surgical neck is really just any area right below the greater and lesser tuberosity. I think it's called the surgical neck because that is the location of fractures, and if you do fracture there, you would have to have surgery. You don't often see a lot of fractures on the anatomical neck. It's just a lot more bone, it's a lot stronger, but you definitely see as it starts to taper down, it gets a little bit skinnier, and we'll see more possible fractures there. And then we have our deltoid tuberosity. This is going to be on the lateral side because the deltoid is going to cap the shoulder, so as they come in anterior posterior, it's going to just have a tuberosity. A tuberosity is just anything that sticks out. So this is kind of really the only thing that is mid humerus, so it's pretty easy to find, but that's going to be your insertion point for the deltoid muscle. And then we have our glenohumeral ligaments. These ligaments are not very big, they are not very strong, and they're really not ligaments in themselves. These are also just kind of thickenings of the joint capsule. So like the glenoid labrum, we have our superior, middle, and inferior glenohumeral ligaments, but they're really just thickened areas of the joint capsule, and they're not really standalone ligaments. You know, if you were to dissect someone and you actually looked up here at the AC ligaments, I mean, these ligaments are their classic standalone. You dissect somebody, you see them there, they're obvious and they're strong. The glenohumeral ligaments, on the other hand, you can't even tell where they start and where they stop because your entire glenohumeral joint is surrounded by the joint capsule. Within that joint capsule, there's going to be a little bit thicker areas, but unless you cut the entire joint capsule off and you held it up to the light to see which area is thicker, you can't even really tell where these ligaments are. However, if you did look up at the light, you could see that there are 3 distinct ligaments. They're all on the anterior aspect, not on the posterior, and they're going to be super and middle and inferior. There is a little bit weaker area between the superior and middle, so if you do dislocate your shoulder, you can have some problems with that area because it is a little bit weaker. Another ligament is your coracohumeral ligament. This is not a very strong ligament. It's not going to help a lot when it comes to stability, but what it does do is limit the amount of translation, the amount of movement of the humeral head when the arm is hanging at the side. So coracohumeral is going to run from the coracoid process to the humeral head. Coracoid process is here, over here, and then it's going to run out to the humeral. So it's just lying right on top of the glenohumeral joint. And its job is, so when your arm is hanging at the side, gravity wants to pull it down. So instead of constantly using our muscles to hold it up, the coracohumeral ligament is also going to help hold it up. So it's a ligament that's on top here that's just there to prevent inferior translation, so the hanging down of the arm, slipping of the arm off the glenoid fossa when it's just hanging there. But as soon as we activate our muscles, then that's going to become kind of null and void because your muscles are a lot stronger. Back to the coracoacromial arch. I've talked to you about the coracoacromial ligament and how that ligament runs from the coracoid process to the acromion. In this picture, here's your acromion and spine of the scapula, here's your clavicle, here's your coracoid process. So this is actually a left arm. The ligament here is actually forming the entire arch. I mentioned this before, this picture is a little bit better, where we have this structure that actually forms an arch with stuff coming out underneath it. This is going to be really important anatomically to understand because this is the location of a ton of injuries. So underneath the coracoacromial arch, we have our humeral head. This arch is there to help basically protect it. It's going to help to prevent too much movement from these structures. We want to keep the humeral head in place. We don't want it dislocating superiorly. So the coracoid process, the acromion process, and the coracoacromial ligament are going to help prevent that. However, we do have major structures coming out of here, the supraspinatus tendon. We have our biceps tendon, and we also have a bursa in there that are possibly all going to get pinched if we do have too much movement of the humeral head superiorly. So it's kind of a catch-22. We want these structures there to act as a roof to help prevent too much motion, but if we have too much motion, then it's going to start hitting, and now those structures are going to become impinged. Here's another picture down here of what the arch looks like and how your supraspinatus tendon comes right underneath. Okay, so that is all of the bony in joints and ligaments. The next section will be of all the muscles.